Our next topic is antimicrobial susceptibility of equine bacterial isolates to inform equine antimicrobial use guidelines. And our speaker is Dr. Kirsten Bailey. She's a research fellow in antimicrobial stewardship at NCAS at the Faculty of Veterinary and Agricultural Sciences. Thank you.
Good morning, everyone. So today I'm going to give you a little bit of insight into antimicrobial stewardship and guidelines and culture and sensitivity testing in equine veterinary medicine. I thought I'd just start off with a, with a couple of highlights about some of the differences between my patients and the doctors, human doctors' patients. My patients can be a bit fractious at times, which can make it challenging to deal with them and inject them, both for myself as a veterinarian, but also for the owners. Their environment can be somewhat less than ideal, squelching around in the mud. There's certainly a lot more environmental, or less control over their environment, I would say, in our infection control practices. And then also, given their size, the volume of drug that we're dealing with is quite a bit bigger too. And this also presents some issues that I'll go into a little bit in a little bit more detail later on. But they're large animals and they need...
Sorry to interrupt. I'll just reshare this because it hasn't come up.
Okay.
Yeah. Screen. Still not coming up. Sorry, everyone. I'm just trying to make sure that the screen shows the correct slide.
Share the desktop.
Yeah, so I have shared the, so this has been shared, and it should, this is the one. So this is the NCAS presentation, and this is what we should be able to see. I'm just going to make sure that that's coming up because it wasn't. Yep, perfect, thank you.
Okay, so I was just touching on a few challenges that we have when dealing with horses, and in particular their large size and therefore the large volumes of antibiotic that they need to have injected, and that this can cause some issues for us, which I'll touch on later on. So, as I'm sure everyone that is listening is aware, antimicrobial use guidelines are a key component of antimicrobial stewardship, both in human medicine and veterinary medicine. And it's important for antimicrobial prescribing guidelines to be evidence-based, but also locally relevant. Internationally, the British Equine Veterinary Association have developed a responsible antimicrobial use policy, which I've got a copy of up here, and apologies that text is probably too small to be able to read. However, I mentioned that it needs to be locally relevant, and there are some recommendations here for treatment of neonatal foals with a 4th generation cephalosporin, which fortunately is not available for veterinary use in Australia at the moment, and hopefully we can keep it that way. But this highlights one of the things that we need to make sure we have locally relevant guidelines. And then in going through the literature to see what evidence there is available for guidelines, and came across a number of studies evaluating antimicrobial susceptibility patterns in bacteria isolated from horses. And initially I thought, oh yay, there's some evidence here, we'll be able to look at this and this will make guideline development a bit easier. However, depending on where they're coming from, I guess what they're recommending is not quite what we would want to be recommending as first-line treatment. So this top paper is from the States, and so prior to 1990, gentamicin and penicillin were the preferred choice for first-line treatment of foal sepsis. And then they changed way back then to amikacin and ampicillin, or amikacin and ceftiofur, which was based on a report by one of the authors about some resistance issues in the Enterobacteriaceae. And so the conclusions of this paper, which was published in 2014, were that amikacin and ampicillin were appropriate first-line choice treatments for foal sepsis, while awaiting culture and sensitivity, and that they were already noticing a reduction in susceptibility of Enterobacteriaceae to ceftiofur since they started using that in the 1990s. Another paper from, I think this one's from the UK, has looked at resistance patterns over time, and they're also seeing an increase in resistance to ceftiofur and gentamicin, and concerningly, an increase in resistance to enrofloxacin in streptococcal species, which when we get into my results a bit later will also be a bit concerning. And it looked like these studies were fairly straightforward to perform. Just have a look at the susceptibility data and churn out some results that this is what the susceptibility patterns are, easy. This one, I've just put an example up there. So they've done cumulative susceptibility of gram-negative, which is the table that's showing, then they've got a gram-positive table, and then they've got an overall table, which when you start trying to look at susceptibility results is not really appropriate at all. Even just looking within the gram-negatives, there are quite a number of Enterobacteriaceae that have intrinsic resistance to ampicillin. Looking at the gram-positives, the Enterococci have intrinsic resistance to the cephalosporins. Some of the, I'll just move to the next. Some of the, this is just a list of some of the intrinsic resistance phenotypes. Streptococcus have a low level intrinsic resistance to aminoglycosides. So just reporting this overall cumulative susceptibility isn't really that informative or useful. So we have some equine antimicrobial prescribing guidelines on our website, and to ensure that they're evidence-based and that the empirical first-line antimicrobial choices are appropriate and locally relevant, I thought, well, let's have a look at our microbiology database from the University Hospital out at Werribee. There are some limitations to this data, that it does represent samples collected from a referral population, so these animals likely represent more complicated cases that may have had a longer treatment history, and so may not represent resistance levels in general practice. But if this is, for want of a better term, the worst case scenario, then it still hopefully is useful for us to tell our primary practitioners what they should be using. So with that in mind, I obtained the data, which has been carefully curated by my colleagues at Werribee, Mark Miranda and Reese Bushell. And I think Glenn Browning's had quite a bit of influence on this as well. And it is a very, very valuable resource. There's data in there from 1999 to 2017. And of this, there are 4,800 equine isolates. And this is just a graph of the number of isolates over the years. And as you can see, there's a bit of a gap there in the middle for the equine isolates. And there was also some concern about how much detail we had about the methods used before 2000 compared to 2005 going onwards. And so the result of that was that I ended up in my data cleaning, removing any records before 2005, and then went through a process of checking all the other records, removing any that didn't have any susceptibility results. There was some in there that was serology or PCR, or they were environmental samples from around the hospital. Some samples that had no growth. Anaerobes, we don't really do much sensitivity testing on, fungus and yeast. And then there are a few miscellaneous samples from various research projects. So I went from 4,800 down to 729 samples, or isolates, which is still a nice large number, but we lost a fair bit along the way. And then to be able to try and find more meaning for this data, I went into our veterinary practice software management system to look at the patient records and try and find out what the sample type was, and also find out the age of the animal. And I have also, while doing that, collected data on what the indication was and what antibiotics were used in the treatment, which I plan to analyse further later on. So the results overall, I've just summarised the top findings. So if we look at the sample type from all horses, the most common sample type having culture and susceptibility results are samples from a synovial structure. So this includes joints, tendon sheaths, bursa, and occasionally a piece of bone from within a joint has been submitted for culture and sensitivity. And this would be a large proportion of a referral equine practice's work, is looking at infected or septic joints or synovial structures. And these are quite often very complicated cases that take a long time to treat and hopefully resolve. The second most common sample type was swabs from exploratory laparotomy incisions. And then our third most common sample type was tracheal lavage samples. I then also just had a look at our foals that were less than a month old, and blood culture for sepsis was the #1 sample type, followed again by synovial structures. Neonatal foals are very prone to sepsis and septic joints, and also patent urachus and umbilical infections. So those results aren't particularly surprising. If we then look by organism via all the horses, our most common isolates were a streptococcus species, followed by a staphylococcus and E. coli. And they're all at quite high numbers, more than 100 isolates, and then going down the list, the numbers get a lot smaller. So I've just broken it down to look at a bit of the sensitivity patterns. And I want everybody to remember what I was saying earlier about intrinsic resistance too. And so I have put up here the gentamicin. And this is showing the number of isolates that were resistant. And you can see the total number up there was 136 samples. So pretty much all of the samples were resistant to gentamicin, but this is one of those intrinsic resistance scenarios, and so it's not really very valuable to look at gentamicin when we're considering streptococcal infections. There was only one isolate over the 12-year period of the beta hemolytic streptococci that was resistant to penicillin, and I'm a bit curious as to whether it was perhaps misclassified. It was from a mare that had a ruptured uterus and a nasty peritonitis, so it was a bit of a mixed growth. But still, in saying that, penicillin is an extremely effective drug against streptococcal infections in horses, and therefore remains highly effective first-line treatment. You'll notice that just down a few bars, ceftiofur has 100% sensitivity as well, and it does have a label claim in horses for use for respiratory tract infections, which is unfortunate. And I'll come back to pros and cons of using penicillin in a little bit. Oh, clicked the wrong thing, sorry. Technical issues today. So next we're going to look at the overall sensitivity of the E. coli isolates. That our critically important antibiotics, ceftiofur and enrofloxacin, have fairly low levels of resistance, and then our first-line treatments, ampicillin and tetracycline, have higher resistance rates, and then gentamicin is still sitting at about having a susceptibility of about 60%. And if I pull out just the septic foals on their own, they had an 88% susceptibility pattern to E. coli. So I feel comfortable saying that for foals with an E. coli infection, that gentamicin is still an appropriate first-line antimicrobial choice. And then looking at the Staphylococcus aureus, this one is a tricky bug for equine practitioners. It is quite common in joint infections, and horses that get staphylococcal infections in their septic arthritis have a poorer prognosis. And there's quite a lot of resistance to penicillin and gentamicin and tetracycline. And critically important drugs have a more predictable sensitivity pattern. And so this is challenging for our practitioners at Werribee. So coming back to Streptococcus, it looks like penicillin is the perfect choice to treat those infections. And we do want it to be the first line choice, but there are some challenges with this. Procaine penicillin in horses has to be given intramuscularly. The dose rate is 22 milligrams per kilogram twice a day, which for a 500 kilogram horse is 36 mils twice a day. And so that's quite a large volume to be sticking into a horse. This picture on the left shows areas where you can inject it, so you can do it in each side of the neck, in the pectoral muscles, or at the back end of the horse. And depending on the temperament of the horse, the back end may not be an option. The pectoral muscles, if you've got quite a large volume, it can be a bit hard putting a full penicillin dose in there. It does have the advantage that if you get a reaction there, that it has gravity on its side to help drain it, in comparison to if they get abscesses on their necks or their rumps. And I think I've got a not so good picture, but this is just an example of a severe reaction. And so one of the problems is if these horses need to be on medication for a longer time, then injecting them in their neck, they get quite sore, and then they won't put their head down and they can't eat. The amount of reactions may be less if it's veterinarians giving the injections compared to owners. And so to have your horse hospitalised so it can be treated by the veterinarian is quite expensive, and depending on what you're trying to treat, it may be something that you want your owner to try and treat, but their skill in injecting can make this an issue as well. And so there's a big push from clients to not give intramuscular injections. So what are our alternatives? So oral medication alternatives that we have are trimethoprim sulfonamides, doxycycline, and then enrofloxacin powder has become quite popular to be given as a paste. And as we looked at earlier, there's very good sensitivity patterns for our Staphylococcus aureus. And I did point out in one of those publications from the UK, I think it was, that they've noticed an increase in resistance to streps against enrofloxacin, and so perhaps this is one of the factors that's influencing that. And then again, when we looked at the Staphylococcus aureus, there was quite a lot of resistance to gentamicin, and so this is an issue for our horses with infections in their synovial structures. And so one of the ways that clinicians try to treat these infections is they can give the gentamicin intravenously, and that's for a 500 kilo horse would be about 33 mils once a day IV. Sometimes you can get owners to give it IM at home, but it's a bit irritant, and again, then you're usually giving them penicillin as well, and so they're getting really sore, so it's not a very practical option. So horses that are hospitalised might also get it intra-articularly. It's a concentration-dependent drug, so getting a high concentration in there can be more effective, and so if it's given an intra-articular dose, then they take that amount of the dose off the systemic dose. And then another option is intravenous regional perfusion, where a tourniquet is placed, and then a catheter is placed into a vein below the tourniquet, and about a third of the daily dose is infused into the vein and kept there for about 20 minutes, and then they remove the tourniquet, and that's to try and get high concentrations at the site of the infection. And so something that I think needs to be explored better is our susceptibility results are looking at 10 micrograms concentration of gentamicin in the disc. And in the if we're giving it systemically, we might be getting about 21 micrograms per mil in the bloodstream. If we give an intra-articular injection, we can get over 1,000 micrograms per mil. So how relevant is our laboratory susceptibility test against 10 micrograms saying that the organism is resistant if we can then stick 1,000 micrograms in the joint? And I think that seems to be something that's often overlooked, but would warrant further investigation. So there's a lot more results that can come out of this database, but this is what I have so far. And so just to summarise, that the beta hemolytic streptococci are pretty much 100% susceptible to penicillin. For neonatal sepsis, penicillin and gentamicin remains a viable first-line empirical choice while awaiting culture and sensitivity results. And then there are a number of challenges in equine veterinary medicine, including volume for injection, injection reactions, the skill of the person injecting, and the effectiveness of oral antimicrobial options that are first-line choices versus our critically important ones. And so that's all I have today. Thank you. Are there any questions?
Kirsten, I would say that a lot of that resonated with me as a horse owner. So I had one horse and did have to go to hospital for 3 days for injections a few years ago. It didn't cost me but she was a very mare sort of mare and had way too much for me to handle at the time. But I guess the thing that I've sort of noticed with horse owners, I think the issue that you talked about with the skill of the injector is just like really, really important. And you know, that I guess also I sort of think about just generally the handling of the antimicrobials by the owner and you know how they use them. Not the mixed ones in the industry, and certainly not just the injectables, but I've seen the topicals just really throwing around a bit. Yeah. And I sort of, you know, say to people like, oh, you know, I don't know, like, you know, it's just penicillin, you know, or just something around. Oh, no. So, sort of maybe a bit off topic, but any sort of view about work to be done to educate parents. I know in Queensland, there's some really public awareness posters that they put around infection control and hygiene and stuff like that. I don't know if there's much of this out there.
We are, through the Equine Veterinary Association, we are trying to target our equine veterinarians and remind them of their responsibilities with dispensing, and that there is the possibility that one day they may not be able to dispense, and that they should be starting to think about how they are billing their services and charging for their professional expertise, and also thinking about why they're giving things and how much they're dispensing. And because yes, and this is not limited to horse owners, small animal owners and farmers as well. If they have some leftover, did you need me? They have some leftover drugs, might just stash that away for a rainy day and bring it out for another animal. And I guess I know pack size is a bit of an issue in human medicine, and for some things that can be an issue for horses, that depending on the number of bottles of penicillin you dispense, whether you give them a 250 ml bottle or a smaller bottle, although generally that would be a 3 to 5 day course, should use up whatever they've been given. But yeah, I think I think the equine veterinary profession, some of the people in the profession are becoming aware of that we need to maintain our social license to be able to prescribe and dispense, and that we need to improve and also educate clients as well. And I know in particular with racehorses, we're trying to work on trainers as well, and teaching them a bit about antimicrobial resistance. So we'll see how we go there. Yes, Kaz.
Did you see any temporal trends in resistance to any of the pathogens?
I haven't looked at it too closely at the moment. There, we have, because it's done by disc, we have the disc diameter, so we can look at that. There is some creep for, I'm pretty sure for E. coli and gentamicin, and I think it was Staphylococcus. We have another PhD student that is working on a second generation cephalosporin gel preparation to be used locally, and so he's been looking at all the musculoskeletal isolates to see if that might be an alternative, and has had a look at that over time. But yeah, I want to look more into that, as well as over time when I went through all the records, I've noticed there's been a change in what they are using locally, and so I'd like to see if that links in anywhere along the way into the resistance picture.
And just my second question, because you use that in cows for mastitis.
Yeah, yeah.
Why isn't it used? Why isn't it used in this? Is it particular temperature injection?
Intramemory only.
Oh, they get
So you'll be treating a relatively serious infection and create a life-threatening diarrhea.
that would be very large one.
Certainly is.
Kirsten, firstly, I admit I've got a few balls in the phone too. I'm interested, is there any data on the variability in the duration of the treatment and owner compliance with the...
Yeah, I don't think we have a lot of data on how good owner compliance is. I think a big area that's lacking in the literature is how long to treat for. And I also want to look at the duration of treatment that's been prescribed in the medical records, because it seems like for some things it's getting longer, like going for a week past clinical sign resolution. And I don't think we don't really have any evidence, hard evidence, for how long we should be treating for. And so I think, yeah, a lot of things. Yeah. Yeah, I know that in dogs, they've repeated some studies similar to what they've done in human medicine for urinary tract infections, and supporting the 3-day course rather than a longer term course for antibiotics. But we're lagging behind in veterinary science, and even with our antimicrobial stewardship project with in the veterinary practices and looking at delayed prescribing, we made up a little table of common diseases and whether they're bacterial or viral, and I was trying to look up what the expected duration of symptoms would be. And it's just so hard to find. All you can find is how long to treat with antibiotics for, which is, I think, again, just plucked from a number of weeks. Yes.
Kirsten, you had one question on right.
Okay.
So if you could repeat the questions.
Okay, so Jamie Byrne, who is actually our PhD student that I was mentioning with the second generation cephalosporin product, has asked, how confident do I feel in the sensitivity testing methodology when a number of the antimicrobials that are being tested do not have a standard published in the CDS methodology? And yes, that is an issue. And then, so there's a CDS method that is used mainly in Australia, I believe, and then there's a CLSI method used more in the United States and becoming more popular in Australia, and then there's UCAST. And I think one of the issues is that, well, CLSI and UCAST do have veterinary streams if you want, but there's still a lot of data lacking, and so it's getting better, but I don't know that I have confidence in any method 100%. It needs a lot of development, and Helen Crabb might be able to speak to this.
So it's well recognised in the veterinary sector that we don't have breakpoints or MIC values for practically all of our veterinary pathogens. So most of the veterinary pathogens that don't have a cutoff, we're using human breakpoint values for to report, and we're in. So VetCast, which is the UCAST veterinary equivalent, and CLSI, they have nothing. There is nothing. When you want to treat a chicken, if you want to treat a swine, if you want to treat a cat and dog for the common urinary tract infection, you're sweet. But if it's anything other than E. coli urinary tract infection, there's nothing. So from a clinical guidance point of view,
in-house, they're working on that, but one of the biggest problems is to set baseline levels is we need MIC data from wild populations of specific organisms, and we don't even have that. So that's a globally recognised issue.
One more?
Yeah, just a quick one, because you touched briefly on sensitivity for veterinary straps around penicillin versus Septifur. And you said that it was unfortunate that why would you use Septifur rather than penicillin? Well, if I'm a practitioner in the field, what would be the incentive for me to use Septifur rather?
There's a smaller volume that needs to be injected for Septifur. I think it is meant to be, the registered product is for intramuscular injection, but I believe it is also used intravenously, so you could avoid your sore muscle issues. With racehorses, procaine, penicillin is a prohibited substance, and so if you wanted to treat with a similar sensitivity spectrum, then you might choose third generation cephalosporin instead to avoid that procaine issue, because apart from procaine, penicillin, all the other antibiotics are not prohibited substances.
Is there a frequency?
I believe it's twice a day, but there's a bit of variation in dose rates in the literature as well, and between foals and adults.
Well, thank you everyone for attending today's Journal Club, and look forward to seeing you at the next one. Thank you, and thank you to Leslie and Kirsten.